Okay, thank you. So I'll be talking about imaging in neuro-ophthalmology, and after a particularly beautiful localization by Dr. Mahesh, uh, really, I just would be actually talking about what options we have for imaging and how should we actually approach. So we'll talk about the various investigations available. What do we have? We have a CT scan, we have an MRI, we have advances in now imaging technology from the basic CT and MRI. You have FLAIR, DWI, DTI, a lot of alphabets, which has to make us learn something more rather than just our ABCDs. And then, of course, CT and MR angios and functional MRI. So we'll just go ahead with CT scan first, the most commonly available investigation. And the key reason why we would order a CT scan would be orbital disorders, brain imaging, which would be an immediate urgent intracranial bleed if it's suspected, say trauma or stroke, and more importantly for our cases, osseous or bony anomalies. The disadvantage is radiation exposure, which has been a lot in discussion during this COVID times. Of course, contrast, because more often than not you need that. And if you're actually not looking at bone, the bone actually creates a lot of artifacts which make it difficult for us to appreciate or understand. Of course, it's a very quick screening time, very low cost, and can be done where MRI imaging is contraindicated. So a CT would be better than an MRI in conditions you can see where, like in this case, you have a subarachnoid bleed or a calcification within the lesion. So if you're looking for calcification, CT would be your investigation of choice and not an MR, where you may just see a diffuse idea but not be as accurate. So I'll just show you a case of a bony problem. This male patient presented to us with sudden onset loss of vision in the left eye, but he got an injury on the right side. So you can see the subcon hemorrhage here, but the loss of vision was here. Now you need to make sense of this. We thought, is he malingering? So he forgotten which side he got injury to, and you can see the VEPs. The left eye is not showing any imaging, any waveforms, and the right is showing you a very good waveform. So you can do a very good reconstruction of the skull on a CT, and you can see actually the trauma line coming from here on the right side on the forehead, going right up to the canal onto the left side. The right-sided orbital canal is absolutely free from injury. So this can help us to actually trace trauma and where else trauma is there in the eye. A patient of optic atrophy, gradually progressive loss of vision, disc pallor came to us. We thought of compressive optic neuropathy, hereditary toxic, nothing worked. This was the MRI and really was not telling us much, but you could see just one thing gave us a suggestion that the optic nerves are tapering down somewhere. You can see the CT showing us beautifully a compressive optic neuropathy because of osteopetrosis, something that could have been missed if the MRI only was screened and you had not taken into consideration the osseous changes. So CT is important for bony lesions, hemorrhages, an early quick screening space occupying lesion, calcification, and cysticercosis. In this case, we could see a calcified intramuscular cysticercosis in the orbit. Alternatively, the MRI is a choice when you want to look at the brain parenchyma in great depth and try to understand what's happening there. A lot of newer applications have come into the MR, and it's better if you're looking at brainstem, fine lesions like infarct, small abscesses, tumors, meningeal and dural inflammations, cavernous sinus lesions, and for very small or fine aneurysms. This was a patient who presented with sudden onset unilateral loss of vision. The other eye was normal, left papillitis. Do we image, and for what? Not only are we imaging for space occupying lesions, MRIs now are indicated specifically all patients of optic neuritis, and in which you want to rule out or suspect multiple sclerosis. And also now advances in imaging are telling us that we could suspect NMO-MOG kind of involvement based on the pattern of involvement of the optic nerves and chiasma and of the brain. So it could give us an idea even before serology as to whether we are looking at multiple sclerosis, NMO, or MOG. So essentially, MRI has now become an extremely important investigation of tool. And of course, as per ONTT, it gave us a very good idea about the prognosis of a patient of optic neuritis developing multiple sclerosis in the long term. So one would say do image on all optic neuritis, but essential in recurrent optic neuritis, atypical optic neuritis, which may suggest NMO-MOG. Keen to know about long-term prognosis, and acute optic neuritis in children, do a T2 weighted MRI with flare and contrast. Another optic neuropathy, a young male presented with bilateral left eye first, right eye subsequently. You can see the fundus essentially normal, a shade of a minimal pallor on the sides temporally. We are showing a delayed pattern, but a field that is not very, that is equivocal. So would you image? You could say it's a bilateral retrobulbar neuritis. You would image because it's atypical, it's bilateral. Already there is this pallor, and the vision loss was for more than 3 weeks. So atypical image, the patient actually had a pituitary macroadenoma, and that's why imaging becomes important in almost all cases. Another case of progressive loss of vision, basically diagnosed as atrophic papilledema. Do we attempt optic nerve sheath fenestration? You could see there's a lot of fluid, although the optic nerves are also atrophic, so the prognosis was not so good, but there is a good cushion of fluid. So we decided to go ahead with optic nerve sheath fenestration, and you can see the improvement in the fields, and the patient actually recovered to 618. Another case of bilateral disc edema presenting with mild transient obscurations of vision. So basically diagnosed as IIH, but this is a diagnosis of exclusion. You must do MRI to rule out a space occupying lesion. And in cases of IIH, which may present atypically, you may need to go ahead with an MRV to look for venous sinus thrombosis, because that may be an important cause for the raised ICT and may require intervention separate from the IIH. Case of unilateral pale disc edema, possibly NAION. Do you need to image? Really, NAION is a diagnosis they made clinically, but now we have diffusion weighted imaging that may over time be able to help us to differentiate in those borderline cases where we are not clear whether it's an ischemic neuropathy or an atypical optic neuritis like MOG or NMO or MOG that can present in an older population. So till now we used to think older age group, think AION, but now because you have atypical presentations of optic neuritis, maybe in the long term, a diffusion weighted imaging may help. The other conditions where you may require are motility defects. So acute onset third nerve, look for pupillary involvement. You must do an MRA with an MRI. If the pupil is spared, if the ophthalmoplegia is complete, look for vascular causes and follow up. If no improvement, you may require imaging. However, if the presentation is partial, even if the pupil is spared, you need to investigate an image because it could be an evolving aneurysm that needs to be identified early. So an MRI along with an MR angio or a CETO angio would be extremely helpful. And finally, a gaze palsy, a patient with a right-sided gaze palsy. He had a normal CT scan done outside, but clinically looking at gaze palsy, we did an imaging. You can see that this was a lesion, an MRI lesion picked up on the MRI on the paramedian pontine region, missed on the CT because CT cannot image that region well. So post ATD therapy, you can see the patient was improved, and CT may miss these diagnoses. So essentially to say, imaging is essential, localize and inform your radiologist what you require to look up. Thank you very much.